We are living through huge upheaval, an upheaval that has further unearthed the grossly unequal foundation on which our society has been built upon. A society that was not built with Black people or women in mind. This experience is compounded in those with intersecting identities. The current pandemic has further unearthed the gross inequality existing in the current health system and the disproportionate economic fallout. We see that current outcry against structural and interpersonal violence through movements like Black Lives Matter and the gender-based violence protest, as well as many others. Today, we are gathered here to speak about the impact of racial and gender bias on patients. For it is the patients, with their lives at stake, who bear the full brunt of these biases that permeates through all levels of society, as health does not exist as a silo, but is closely interlocked with these injustices. Today, we are fortunate to be joined by Prof. Ramugondo, who is the Deputy Dean of Postgrad Education at UCT Faculty of Health Science. She has served as Special Advisor to the VC on Transformation. She has been Chair of Academic Freedom Committee and Co-Chair of the Curriculum Change Working Group, and is on the advisory board of the African Gender Institute. Her scholarship on intergenerational play led to conceptualization of occupational consciousness informed by liberation and philosophy of coloniality. Dr. Ned is also joining us today. Unfortunately, we can't see her because she's had camera issues, but she'll definitely still be an active member of our discussion. Dr. Ned is a lecturer at the Center of Disability and Rehab Studies within the Department of Global Health at Stellenbosch University. She is also the Deputy Chairperson of the Western Cape Rehab Center. And a crucial finding in her PhD is the need for decolonization to be declared a negative determinant of health. She is also a recipient of the 2019 Mail and Guardian 200 Young Leaders Award. And we also have joined with us Dr. Sindi van Zyl, who is a physician and an avid patient activist through her various platforms, including social media and her regular Sidebar with Sindi sessions on Kaya FM, where she discusses various health issues with particular focus on HIV and mental health. So clearly today we have a panel of highly esteemed guests, and we look forward to really tackling this issue today. So we'll be tackling this issue surrounding three core topics. Firstly, we'll address what is the problem, where we talk about the existence of these biases. Secondly, we'll address what are the ramifications of these biases. And thirdly, we'll discuss what are the avenues forward for our societies. We will now start discussing the first issue, the existence of these biases. And I'd like to ask Prof. Ramugondo, will you please start us off on this discussion?
Okay, thank you for me. It's a real privilege to be invited to be part of this very important conversation. And I like the way you contextualize this conversation in relation to what we are seeing currently in the world. COVID-19 having affected everyone globally, and the emerging of voices around Black Lives Matter. And these are protests that completely resonate with what we've seen, not only in South Africa, but other parts of the world, including South America. When I looked at the questions and then I saw the focus on bias, it didn't take me long to revisit my understanding of bias and what that means. And I think it's always useful to remind people that bias can be positive. So people can be treated in ways that favor them on the basis of identity. And what we've seen mostly is that race and gender sometimes can accrue positive treatment for some. And that when we talk about bias in the sense where people are ill-treated because bias serves against them, we're actually talking about prejudice. And from what I have read and heard from people who see patients every day, because in my work, I no longer have the privilege of working with patients directly. So a lot of what I understand and know about prejudice against patients, and mostly Black and women, and I like the framing of prejudice that you are speaking about, Funmi, along intersectional lines, where you see race and gender intersecting in ways that are reconstitutive rather than additive, where basically you can be assured that if you are Black and a woman, you will find that you bear the brunt of the prejudices that people face in healthcare. And it's been quite scary to hear that women who are Black often face very poor health outcomes, even when they could afford services. And there's definitely evidence where women with cervical cancer would not be prioritized for life-saving surgical intervention, where compared to their white counterparts, they are last on the list of priority, with absolutely harrowing outcomes for their lives. We've also heard, and this has been reports that I've heard from colleagues in South Africa around how treatment in relation to HIV and AIDS sometimes shows trends that can be very disturbing, where even as a middle income earner, a Black woman might find that they don't get the care that their white counterparts would have access to. Side effects to ARVs not taken care of as they should. And when you hear such stories, it makes it very clear that, you know, when you hear about how sometimes Black people avoid going to healthcare services because they are not certain that they will be treated with care, you can understand where that comes from. I'll stop there for now. I'm keen to come back to the further questions that you ask around the why and what avenues are available for us to begin to address this issue. Thank you.
Would anyone else like to continue where Prof. Ramugondo has started the conversation?
Yes, I can come in. Lieketseng here. Thank you once again for trusting me to come and contribute to this critical discussion. in answering the question, I thought that I would basically center my responses within the space that I'm in, which is the disability sector, as well as rehabilitation then. And I think to build on what Elelwani has already said, I think what is evident both from my experience when I was still practicing as a clinician, as well as from the research that I conduct now, what is evident is that even within the disability community, we have those who are on the privileged side, and we also have those who are on the margins and are disadvantaged. And there's a lot of research that shows how some persons with disabilities are experiencing not only poorer health, but also they're experiencing a lot of challenges with regards to access to health services and other services, even related to issues of livelihood, but with the understanding that health itself is a prerequisite for participation in other opportunities across aspects of life. So often then the disadvantaged persons with disabilities are those who live the core effects of some of the things that Elelwani was alluding to. So those who live the core effects of enslavement, the core effects of racism, capitalism, spirit of patriarchy, and apartheid in the context of South Africa. And so what this means then is that even if you come across two people with the very same impairment, the disability experience is never the same because of these intersectional issues that you've highlighted. And I think then what it also makes us look into, particularly in the health system, is that what is linked to this problem is the notion of the knowledge order as well. We know in the healthcare system that biomedicine plays its dominant role, while other knowledges or other ways of healing are pushed to the margins in a way. So you would often find that any collaborations between indigenous ways of healing as well as biomedicine, they remain fraught with unresolved issues of mistrust and tension. And biomedicine within healthcare wants to present itself as the standard, and everything else must meet that. So you'd often see things where biomedicine is presented as scientific and superior in terms of health, and while indigenous ways of healing are seen as backward, they're dangerous, they're unscientific, and that often presents quite an awkward conflict between the patients as well as the practitioners. So this is to say, even the healthcare practitioners who come from these communities that value indigenous ways of healing, they find such a difficult time in servicing humanity in these healthcare institutions, because they often have them to leave themselves behind as well. And you often hear people shouting at patients with the mention of, I have consulted my indigenous healer. So those are some of the issues that come up. And lastly, I think what I wanted to raise is the other root of the problem here is what happened in the apartheid era in South Africa, is that the persistent racial and spatial segregations that we see today, they still continue to reproduce some of the issues we saw in the apartheid era. So when we see the existing overcrowded clinics, the violence, the poor mobility issues, the poor services, and other deprivations that are seen mostly in rural areas and in townships, they are a consequence of the design of the apartheid era. So these things then continue to play themselves out, and often we are not willing to engage on some of these issues, or why even resistant. And it's easy when you're on the privileged side to resist change, because what does it mean for the power or the social location that you are occupying? So I think those are some of the issues that give us perspective in terms of the problems that we are facing today in South Africa.
So thank you so much. That it's long overdue. I'm very glad that you framed it in the way that you have, and I'm glad that the Prof has also, added another layer to it, because I don't think this is something that we speak about a lot in South Africa. Okay, and I mean, I trained at an Afrikaans university, and when I look back at the way we were trained, it takes a lot for you as a Black clinician in training to have empathy for the patients, because the way everything happens, patients are treated like objects and so on, and yet the treatment for a white patient was always different, right? There was always a difference in the way in which a white patient's case was presented, whether it's by the registrars or the senior students or the professors themselves. And then there's always a difference when when they were presenting a Black patient, and even more so when they were dealing with black women. And this is something that persists through the medical system. So I'm very happy that you're aware of it. For me, I'm very glad that you're aware of it, because it means that you are going to be a different clinician, and you're going to make sure that the people around you are different. And this is really what needs to happen, right? I'm not a policy informant anyway. I haven't done any research, no papers. But what I'm very passionate about is changing things from a medical school level, right? You don't have to treat patients the way the professors treat them. You don't have to treat patients the way the registrars treat them. And many of them have blind spots, right? They don't even realize that they're talking down to a patient because she's Black and she's female, until you point it out to them. And I say this because I'm married into an Afrikaans family, right? And I've been married to my husband for 16 years. And he's very aware, he's very open-minded about life, but obviously there are people in his family or extended family or in the friendship circles who don't even realize just how biased they are and prejudiced they are towards Black women until they're confronted by me, right? So they meet me and they start acting up, and they can't even understand why they're acting up. So this is what apartheid has done to people, and we need to make people aware of it. And such conversations need courage. So for me, you've done a great thing, and this conversation has to continue beyond this platform. It's something that you need to make your peers aware of. Unless we change, right? Unless we change and we make the people around us change, nothing is going to change. And I'll give another example. I mean, Prof spoke about cervical smears and so on. Black women tend to carry the burden of the world on their shoulders, right? It's almost like we are brought up to tolerate suffering because that is how life is. We come into this world, things are hard, and then you develop you don't speak up when things are not okay. You see that, for me, I'm sure you see this all the time. A Black woman, even if she's in pain, because that is just how life is. We are begezela, right? And then if she does speak up about having pain, the people around her are angry at her for speaking up, because how? People do that, right? And again, it's a matter of highlighting those issues and pointing out that, sister, if she says she's in pain, she's in pain. Yes, she's a woman. Yes, she's just given birth, but she can't walk. She says she's in pain, so please give her the pain relief that she needs. So these conversations are important, and it's amazing. As I said, when I saw it, when you emailed me, I thought to myself, oh my gosh, a young Black medical student that is going to change the world, because that is exactly what you're going to do. No one has the courage to speak about these things, right? I left Takis in 2005. I used to speak up where I could. There comes a point where you start worrying about your marks and getting into trouble and failing and being pushed out of the system because of being outspoken. That's another thing we need to speak about, right? So there's so many things working against us and preventing us from speaking up. So I'm happy that you've done this, and I'm happy that this is going to be out there for people to understand and accept. Being a Black woman in the system is not easy at all. And some of the health outcomes that we see come from that thing I'm speaking about. You'd rather keep quiet and suffer in silence than risk going into the system and getting ridiculed or getting interrogated or getting treated badly. You know, I mean, one of the main reasons why I'm the medical doctor that I am is because I've also been treated badly in the system. Way before I became a medical student, I remember going to Steve Biko Academic, which was not Steve Biko back then, but I had an abscess. I'll tell this one story, then we'll continue the conversation. I had an abscess under my armpit, and I couldn't wear a bra. So I wore a nice top, a baggish top, and I went to the surgical OPD, and I was seen by the registrars, and then the senior registrar was a white woman, and she took it upon herself to shout at me in front of everybody, including the registrars, and she kept asking me, what do I think this is? Why did I think it was okay for me to come to SOPD without a bra on, right? The abscess was huge. There was no way that I could have put in a bra, but she took time out. I'm lying there, I'm in agony. All I wanted, you know, because I get these recurrent abscesses, all I wanted was them to incise this thing and drain it so I could go home. And this woman shouted and shouted and shouted at me, and all I did was keep quiet. But those experiences, such experiences, made, because I always knew I was going to be a doctor, made me realize, Wuti, when I'm a medical doctor, let no patient ever suffer such humiliation at my hands, right? Or around me, or, you know, just no one needs to go through that, right? No one needs to go through that. So for me, I am very proud of you, and you have a lot of work to do. This platform is just the beginning of a journey, because you're going to have to be brave. You're going to have to speak up, and you're going to have to tell seniors not to speak to patients like that. You're going to have to tell seniors that, listen, I don't think that's the right treatment for that patient. Are you doing this because she's Black? You know, you're going to have to start saying things like that. And slowly but surely, things are going to change. Prof and Dr. Ned, you know, can inform policy to make sure that the blind spots fall away, because the blind spots are still there. And we inherited a very sad system. I think apartheid broke the country in so many ways. In so many ways, there's so much work to be done, but this is a great start. I haven't seen or heard of a paper like this, certainly not in the way that you framed it. So I'm very happy about this.
I'd firstly like to say thank you for the recognition. I think I really do appreciate it, because especially as a student in this environment, it can be very silencing at times. But I felt a sense of camaraderie among Black people and among women during this time. They've all kind of, as you mentioned earlier, it's kind of that issue of, from young, we're taught we need to be strong. We're taught the world is not made for us. We need to force ourselves into it. And now, in my position, I consider, if I am fighting these struggles in what I am doing, the struggle, like, we are meant to help patients, essentially, that's what we're meant to do. And if we ourselves are fighting to help, there's something very just uncomfortable about that idea that we definitely do need to address. And we need to speak about it more and more often, and just hope that it will hit, like, it won't fall on deaf ears, but eventually people will wake up and realize and be galvanized into action to address this issue, because it's just historically, I can't even put it into words how the subjugation of these groups has existed for so long, for over many years. And we're only now beginning to properly and consistently and without apologies, without keeping quiet, starting to address it. And I think the ramifications, moving on to our next issue, are definitely large. And you have mentioned a few already. Are there any other ramifications you'd like to mention about these biases?
Yeah, is it okay if I start? Yeah, so I think it is good to make it clear that when we talk about bias, prejudice, and stereotypes, we are really talking about the symptoms. So we're talking about what is on the surface, what you experience as a Black person or as a Black woman, yeah, sometimes as a white woman, sometimes as a disabled person, but oftentimes when you are all those things, you know, that pit you against a system that was not built for you as a woman, as a Black person, as a disabled Black woman who also is the member of the LGBTQIA plus community. The stakes against you are so high that oftentimes when you experience that treatment, you have people turn around and say, well, are you sure? Right? And then you are forced to think about these things as an individual. And then you are then burdened with the labor of finding the evidence for it. It becomes absolutely clear that this is war that you can't win, right? And someone, a colleague that I work with in the deanery in the Faculty of Health Sciences, Prof. Ambrose Wonkum, put it very beautifully. I mean, let me put it this way, succinctly. I mean, it was brutally succinct, and it was very clear. When he said, you know, when we were all forced to witness the brutal killing of George Floyd with the neck on the neck, with the knee on the neck of George Floyd, what that symbolized was absolutely clear. There you have a human being who needs oxygen to reach their brain, right, to function. But what happens is that the neck of the police person is placed on the neck. The knee is placed on the neck to stop exactly that, to stop the breathing of a human being. And when you think about it further, right, and you think about the video and you see and hear people saying, he can't breathe, and he's telling you he can't breathe. And then nothing is done to show that the people who are witnessing this, plus the person who's going through this, are believed by those with the power to block the circulation of oxygen and blood to the brain. Yeah, it becomes very clear. So you can suffer and say that you are suffering and not be believed, right? It becomes very, very, very telling how prejudice, stereotypes, ill treatment is merely a symptom, right? What we need to understand is that below the surface is where lies what Lieketseng, Dr. Ned was talking about, right? So the systemic issues that we are all talking about, Dr. Sindi recognizes, you recognize, Funmi, that there is something else here that is going on, right? So the why question, right? Why these biases? Why these stereotypes? These stereotypes, these prejudices against Black people in general? Okay, because systemic racism, which translates in structural racism, epistemic racism, institutional racism, symbolic racism, is so embedded in everything that we do that to only point at the surface experiences will just leave us busy with the work of justifying that, of course, we are going through these experiences and providing the evidence. Whereas the work really needs to be about dismantling what is beneath the surface. So this is systemic racism, what coloniality and colonialism have left embedded in society, gross economic inequality, racialized capitalism, the neoliberal agenda, which drives healthcare, which means that profit must trump life itself, right? So then when we graduate, we fit into a system and a healthcare system which was never made for human life. The same way that that knee against the neck does to the human body. This is not a system that creates life. It's a system that kills life. So when you part of that system and you find yourself perpetuating it yourself, where you participate in your own oppression, it becomes even devastating. I mean, just to close off, you know, this past week has been heavy. Some of you will know that the report that was released by UCT's council, which tells a story about how Prof. Mayosi came to a point where he died by suicide. Why that came about. I mean, I was reminded of engagements with students at the time when students had occupied the Dean Suite, and we were called in. At the time I was doing work university-wide around decolonizing curricula as part of the curriculum change working group. And we were called in because students were saying, we are not being heard, right? And Prof. Mayosi invited us to come and engage students because the demands that students were raising, to him, he could already see that this speaks to the surface issues, right? Students were talking about how they face bias in assessment, in the way they are assessed, that sometimes it's really about accent. If you speak and come across in a particular way, you either get good marks or you get bad marks. Of course, with prejudice against those who do not speak in the way that is expected. If you're Black, if you don't have the Model C accent, you are doomed, right? So even at that point, we signaled to students that, you know, it's like an iceberg, this thing, right? So the issues and the demands that you're raising are the tip of the iceberg. We all need to go below the surface and figure out what lies beneath it, beneath the surface, and the structural and leads to these things that we experience. So I think it's the why question is very critical, because then we would understand the ramifications, right? So that we will see why with COVID-19, as we are experiencing it, we again are finding that Black people all over the world are disproportionately affected. Just to finish off, the one story based on evidence that some of our colleagues are beginning to share with us is this, right? You know about the comorbidities, diabetes and hypertension, especially if you are older, right? So if you are 70 years old This is what they're telling us. If you're 70 years old and you're Black and you are urban, you probably won't make it if you are infected with COVID. So the poor health outcomes across income. So it doesn't matter how much you earn. But if you are if you're a 70-year-old urban Black person, you are going, if you are going to be infected, your health outcomes will be poor. Can you see how dire the situation is? It's, I mean, we're talking about us. Even if we call ourselves the educated elite, something else is going on such that you are not safe, even if your income looks better off. You're not safe. So the ramifications are dire unless we solve the structural issues. I'll stop there now.
Yes, just to add on that, when it comes to ramifications, I mean, when you said the question for me, all I could think of is the issue of institutionalization of services. You know, in the work of disability and rehabilitation, we always advocate for community-based services. But a lot of resources actually go to institutions for services. But this is in the context where we know there has been a lot of research that is done where persons with disabilities, especially then those in rural areas, and more so women then with the other complexities that they are faced with, as mentioned earlier, they are still faced with quite a lot of barriers in terms of transport, financial, long distances, and all these things, they hinder access. So to me, it doesn't make sense why we would then continue with prioritizing institutionalization of services when we know that given the design that we have, which was given for us, and as Elelwani is saying, it was never designed for the Black woman in a rural area. So in light of these barriers then, why are we still not shifting resources? And this is even despite the calls that have been there about decentralize, redistribute human resources. But even today, there's recent research where we were analyzing distribution of human resources for rehabilitation in South Africa, so across the provinces. And from that research, you would see that, so even without just looking at the fact that there is less resources for disability, but even when you look across the provinces, you would see that even today, it is only the more urbanized provinces that have more resources. So they have more rehabilitation professionals, for instance, and that would be Western Cape, Gauteng, and KZN. The other provinces do have less resources. And when you look at that then, and you look at the census results, or the latest, the community survey, you would see that these provinces that actually have less human resources for healthcare, they actually have higher prevalence of disability. So that is what we are still sitting with now. And even when you go deeper in these provinces, it is mostly those areas that are situated far from the services that are suffering the most. So you get a woman who's, just to relate another example related to what Elelwani was raising, you get a disabled woman who's unable to honor an appointment in a hospital because it's far. They were not able to get the money needed for them to be transported to the hospital. And by the time they go to the hospital or to the clinic, you get practitioners who are shouting at this woman without even giving them an opportunity to state what is happening. So we don't even want to listen. We don't even want to listen. And you would often hear issues, when you raise these issues, you'd often hear conversations about, but we are all equal, but we are treating everyone equal. But here are patients, they are telling you that this is the issue. You know, I couldn't find someone to leave my children with. I couldn't find money. I didn't find transport. You know, those are all the issues that the patients often face. More especially in rural areas, but as practitioners in healthcare, we do not want to listen. And so it makes much more sense to then prioritize community-based services, so that we can really practice being committed to serving humanity. So as Elelwani was saying, we have this system which is not designed to serve you, but this system, in fact, in its own iniquities, it reproduces the ill health, it reproduces, it is debilitating, it is disabling, you know. So when you operate then in such a system, through its structures, it reproduces the very issues. So that's why we still sit today with a persistent quadruple burden of disease. But also even that, so even if people could then argue that we are improving in terms of mortality rate, but also the people who are living longer, they live with impairments, and most of these impairments are actually associated with the quadruple burden of disease. So in a way, we are not working towards building healthy communities. We are working towards what Elelwani was saying, creating dependency on these systems, creating dependency on the institutions, so that you can keep coming. But what about the challenges that people are experiencing to keep coming to these institutions, you know? So I think that is some of the ramifications that we are seeing and we're experiencing today. Another study that I did with disabled youth in Ofinzaba, it was also very much telling about the attitudes that we have towards young Black disabled youth, where you get practitioners saying, no, they are lazy, they wanting to misuse disability grant, that's why they are not able to come up with something better for their lives. And these are prejudices and attitudes that are there. So even as they are coming, they are already labeled as fitting within this kind of profile. So you get service providers who are sitting in their offices with all the information about programs that they have, and are expecting disabled youth to come and access those services. But without the information, how are they going to access them? And then when they are not accessing, the reasons would always automatically then be, no, they are lazy, they are just dependent on a disability grant. So those are some of the issues that are very much problematic, and often then it is those in rural areas, women, people in the LGBTQIA+ community that are facing much more of these challenges. So it's quite saddening, really, and I think Elelwani has already summarized it very well in that regard. So I'm happy to hand over to Sindi if she has anything to add.
Yeah, thank you so much. I think both of you, Prof and Dr. Ned, have captured it so well. You know what the ramifications are of such a system, and you know, when we become barriers to healthcare, then something has to change. And again, I'll come back to the medical schools where I think the training has to start there, and the nursing colleges as well. We need to change people's ideas about human beings. I feel as if, I also feel, Prof, especially, this is especially for you, that when they are screening potential medical students, maybe there needs to be a test on empathy or something. There needs to be something else apart from academics, because academics are not enough. Academics don't save lives, right? You can know everything under the sun, but if you can't impart something else into a situation, it's not going to help. You know, when I look at the HIV field, which is where I mostly work, so I'm a GP with a special interest in HIV, and I look at what's happening now with lockdown. People are afraid to go to clinics that are in their areas. People are in lockdown in different parts of the country, so many people are not where they normally get their medication, but they're afraid of going to those clinics because of what they've heard of how people are treated, or because of the stigma, because maybe they know someone in their hometown who works at a clinic who's going to tell everyone, oh, Sindi came to fetch medication. So there's so much that we need to look inside ourselves and just ask ourselves, if I was in those shoes, if it was me, what would I want to be done? Maybe that's what people need to do. If I was in those shoes, what would I want? I mean, I remember giving a talk to some nurses, and I say to them, the way I treat patients, I always say to myself, I don't know what this person had to go through to get here. Maybe uvuke ekuseni and borrowed money from the neighbor, borrowed 10 Rand from the neighbor, and he must pay it back somehow. And that 10 Rand is going to get him to the clinic and get him back home. But now, if he gets to the clinic and I'm in a bad mood, or I need to go for tea, or I haven't eaten lunch and I'm grumpy, and I treat that person badly and they leave, what if they don't come back? So I always say that, always ask yourself, what did this person have to do to get here, right? And now that they're here, can I at least do everything correctly so that in case I never see them again, wherever they go, wherever else they go, they will get the help that they need. A simple thing like explaining what a medication is. A simple thing like telling a patient that this is the ARV that you're on. It's called Atroiza. And if you don't know how to pronounce it, I'll write it down for you. So at least if I never see that person again and they end up in KZN or they end up in Zimbabwe, I don't know, at least they can explain where they are, what they're on, and the continuation of care, you know, can happen. But we're just stuck in a system that doesn't know how to speak to the people in the system. You know, it's a little thing, the small nuances, and I think those things can be taught in medical school. I refuse to believe that we are just going to keep on training out, you know, doctors and nurses that don't have sensitivity around this. We need to make a difference. Maybe there should be a module, Prof. There should be a module on this in the medical schools, just sensitizing people to your biases and your prejudices, because we all have biases and prejudices. I mean, Dr. Ned mentioned the LGBTQIA community. When I give talks around that, I always give examples of countries where it's illegal, right, to be a part of the LGBTQIA plus community. And there are countries where they would use mayonnaise as lubricant, right? So people that are engaging in anal sex don't have access to lubricants. They don't have access to the condoms that they need. So they resort to whatever they have. But it's because this country has decided that we are not going to allow such behavior. Same thing with abortion. You know, if you think about termination of pregnancy, in all the countries where termination of pregnancy is illegal, right? It's not that termination of pregnancies are not happening. They are still going to continue, but they're going to happen in an unsafe way. So do we want to be responsible for the death of people because we are bringing our prejudices and our biases to the table and enforcing them as law? So those are the kinds of things that I think, you know, if we can get medical students and young nurses and just young healthcare professionals start thinking about, you know, we can make a change. We can make a meaningful change. I think the older generation is going to take that much longer to change. I know I've tried, but I think the young people, for me, your generation has a chance. And I keep saying this because I'm just so excited to see you're aware of this. I'm just so excited that you don't have this blind spot about the system that we're in. But we're relying on you guys and Prof and Dr. Ned to put things in place to make sure that people are trained around being sensitive to people with disabilities, being sensitive to the LGBTQIA plus community, being sensitive to Black women, speaking to people in a way that they understand, that makes sense to them, so that they can get the care that they need.
Yeah, I wanted to highlight something else that's related to what you just mentioned, Cindy. I think this also is shown very well in terms of how we work as a team in healthcare. So to show that we never center our patients in a way and never bother to understand the situation that people are faced with on a daily basis. And this is always evident in how, so Sindi, for instance, we are seeing the same patient. You give them an appointment for Monday. I'm also seeing that same patient. I give them an appointment for Wednesday. Elelwani gives them an appointment for Friday. Like it's appalling. I'm like, I don't know why. I don't know why we keep doing such things, you know. Now you get a patient who must be in and out of the hospital, and it doesn't matter, and no one actually bothers to ask how this will implicate the patient in some way. So I think those problems of disciplines that also need to be addressed, that further perpetuate some of these issues that our patients are actually facing on a daily basis.
Just to respond to what you three have all mentioned in this issue of ramifications, I feel like especially with you, Prof, and also Dr. Ned, I think you've really spoken to the essence of the falsehood of upward mobility, in the sense that for many South Africans, that option is not even there. That, or even to cross it is a difficulty that only the rare few are by chance or like able to do. And then that issue of, once you say, for example, have achieved this upward mobility, you still face certain issues regarding your race, regarding your gender, regarding your sexual orientation. And it's because of these structural violences that exist. And I like how you framed it, Prof, in terms of saying how biases, prejudices, stereotypes are just symptoms of these issues. And also, Dr. Sindi, when you said while you were speaking, you mentioned how prejudices equal death in the healthcare setting. It's not just internal biases that have no ramifications in the real world. There are actual lives are at stakes. And I think only once people understand the severity of the ramifications can we begin to move forward.